I'm just going to talk now a little bit about our perspective on surgery and how it has changed and how the role of papillomavirus, that you've heard a lot about in the actual literature. The purpose of this event, as we've already spoken about, is to really raise awareness for head and neck cancer, have a celebration of life, of all of those days that we have, here with all the ones that we actually care about, and also pay our respects to all the patients that really that we've lost. This is still a devastating cancer. It still claims a lot of lives every year. So we certainly want to pay our respects to those patients as well, and their families. So what is head and neck cancer? It's basically any lesion that develops that's malignant within the actual head and neck. It includes the mouth, the skin of the throat, the oropharynx, the salivary glands, and the thyroid gland. Of all of these sites, oral cavity cancer is the most common, and it accounts for about 40,000 patients in the U.S. that are diagnosed every year, and about 300,000 patients across the world. And if we look at that from a timeline, we see about 100 new patients being diagnosed with head and neck cancer in the United States every year. And we have about 9,000 patients that die from head and neck cancer. And that's about one patient every hour of every day, 365 days a year. So it still claims, unfortunately, a lot of lives. The signs and symptoms of head and neck cancer, as many of you have experienced, are really are asymptomatic in the early stages. As cancers progress, you can have a sore, you can have painfulness, you can have numbness, a swelling or a mass inside the mouth or in the neck. May have difficulty with chewing, speaking. You may have changes in your bite. So these are the types of things that we can see. You can certainly get hoarseness and those types of things as well. When we look at head and neck cancer and compare it to, for example, cancers of the cervix, and this is an important point where we as medical practitioners, and as you as patients and the public, we don't do a really good job in public awareness. Why programs like this are very important, because there's not a woman of childbearing age that does not have a pap smear. However, there's only about 50% of patients that are screened for head and neck cancer, and this can be done by their primary care physician or their dentist. So a lot of patients that we see that have head and neck cancer are diagnosed with advanced stage disease. So about 50% of the patients now that we see are diagnosed with either stage 3 or stage 4 types of cancers. And obviously the more of an advanced stage that you have, the more complex your treatment becomes. Early stage lesions that we can manage with surgery. Once you get into stage 3 and stage 4, we often add radiation and chemotherapy, and all that addition of treatment adds more complexity, more time off work, more morbidity, and also kind of increases the risk that the cancer might come back. When we think about these cancers and how they progress, and patients will often have this type of report, is that they woke up and the lesion was just there, or it had been there for a long time and no one had noticed it. But we know that biologically these cancers progress in a very systematic fashion over a long period of time. So what we want to have is very localized lesions, ones that are easy for us to see and manage, where we don't have to do a lot of work. A quick operation or a low-dose course of radiation, we're able to manage these lesions. However, when patients get regional problems, which is usually in their neck, associated in the actual head and neck, or they have distant metastasis where the cancer is able to spread beyond their actual clavicles, that's when these lesions become not curable, and we have a lot of trouble. So we want to be on the left-hand side of this whole algorithm. So we want to be able to diagnose patients with early stage precancerous lesions, and not have patients that have either a cancer that's formed or one that's been able to progress and have metastasis. And we have a lot of lesions that look like this, very innocuous, very small. I had a lot more pictures, and Julie, if you know her, told me, take all those pictures out, because all the patients don't want to see those. And so that's what I did. But we have lesions like this, very small, very innocuous, but these can all be of a concern, and they're all on that algorithm in terms of how these cancers actually form and develop. So it's very important for our patients and our public to be able to advocate for having a head and neck cancer examination, for understanding if something is not right, to be your own advocate, to go and find practitioners that will be able to examine you and screen you. We know that genetically these cancers go through a lot of different changes, both pathologically. All patients that have had a cancer diagnosis are very familiar with the concept of a pathology report, because we're all waiting and anxiously trying to see what's on that pathology report. And that's important because for a lesion to look like this inside the mouth, it has to go through all of these changes, from a normal type of pattern here to one that for us looks a little bit more angry and a little bit more aggressive, until you have something here that doesn't have any architecture and therefore becomes a cancer, and then its ability to then spread. So that's what we tend to get concerned about. And all of these patterns now we have found has genetic aberrations associated with it, and this can occur just naturally. It can occur because of environmental factors, smoking, alcohol consumption, and for factors that we haven't quite identified yet. So early detection is certainly something that's very important that we're trying to work on, and trying to stem the tide from these small little lesions progressing and becoming more substantial. Now, it's not unusual now that we have patients like this, that we have patients that are younger, below the age of 40, that have developed head and neck cancer. And 30 years ago, when you talk to physicians who actually managed this, all of our patients were pretty much men, and they were over the age of 60, 65. Nowadays, we have patients that are significantly younger than this, and this is a patient who was in her 30s when she was diagnosed with oral tongue cancer, had a partial glossectomy, had a neck dissection. If those of you want to know what it looks like, that's what it looks like on the operating room table, and that is what the specimen looks like after we're all finished, all labeled in the various levels of the neck. These patients also get reconstruction. We take tissue from a part of the body and transpose it into another part to try to get the best functional outcome that we can. And here she is about 7 years out with a good functional and also aesthetic outcome, but still having the consequences not only of the surgery that we did, but radiation, chemotherapy, having advanced stage cancers, having some difficulties with swallowing, having some dental problems because of the needs of ongoing care. So there are a lot of complexity and morbidity that occurs when you have a lesion like this. We all know the story about Michael Douglas. So he was diagnosed just recently with a head and neck cancer, and his was associated with the papillomavirus. And what does that mean? We've heard actually a lot about this. So now, if we look at what's happened since probably the 1970s to now, we see a significantly more incidence of patients that have human papillomavirus now associated with their cancer. This is commonly seen in areas of the tonsil and of the tongue. It's got a higher incidence in men. It also is associated with an earlier age of diagnosis, so patients are now significantly younger, and it's not uncommon for patients in their 20s and 30s and 40s now to develop head and neck cancer, and it's something that we never saw 30 years ago. We do know that that patients that have HPV positive cancers have a much better prognosis. So it's actually a very important prognostic feature, because if you have a HPV positive associated cancer, your survival and cure rate is significantly better, almost 4 times better actually. So HPV negative cancers with the same treatment have about a 20% 5-year survival, whereas almost 80% if they're HPV positive, and that's a very good feature. The human papillomavirus that causes head and neck cancer is the same one that causes cancer of the cervix too. And HPV's got over 100 subtypes, and it's type 16 and 18 that causes most of the head and neck cancers as well. And we now think that HPV is now an independent risk factor, just like smoking and tobacco, for developing head and neck cancer. So our age of diagnosis has come down, as we know, and it's also allowed us to do kind of other types of surgical operations using a robot to be able to take out those tonsil cancers and things that are actually very hard to get to. A really powerful slide is when we look at the cost of the Human Genome Project and the amount of significance it's had for a patient that have head and neck cancer. About 20 years ago, when the Human Genome Project was first conceived and done, it cost $3 billion to do that project and to sequence a single human genome. Now, we can get a human genome sequence probably in about a week, and it would cost less than $1,000. So the amount of sophistication of our ability to sequence these things has been very powerful. The problem is now we get all this information and we don't know what to do with it. And that's going to be the next 20 or 30 years, is that we're going to figure out how we can target specifically drugs and treatments for each individual and their cancer. So I hope that I'm out of work in 30 years' time, that we don't have to do this. But we've seen some benefits. We've seen a drug that some of you may have received, Erbitux or cetuximab, which is a EGRF specific inhibitor. So some cancers that are positive to this, some patients will get this in combination with radiation to be able to increase the sensitivity and the effectiveness of radiation. And what we really want to do is to find patients like this with early stage cancers, very diligent, great oral hygiene, great dental care, a very small cancer on the gingival margin. Again, we take larger margins around here to make sure we've got the whole cancer out. And here's the lower part of the jawbone along with the teeth. And then be able to place dental implants and then be able to put teeth in. And a relatively minor intervention is something that could have been a life-threatening problem. So that's what we want to have. All of this work is also work that is not just predicated on one specialty or one person. It's all work that's done as a team, and that's the best outcome. So I'm very privileged to be able to work with a great team of doctors and a great medical staff. And I want to thank you for your time. And here's where you are at the Humphrey Cancer Center. And I want to thank you very much.